So I just thought I'd start out with a little bit of background information about the Missouri Telehealth Network, just so you can get an idea of where we started and what we do. We are a department at the University of Missouri School of Medicine, and we're part of a group of departments called Health Outreach, Policy, and Education, or the Office of HOPE, as we like to call it. We started back in 1994, and we have a combination of state funding, federal funding, contract funding, and grant funding. Back in the day, we built a telemedicine network that connected specialists to their patients in rural areas. And that was kind of how telemedicine started. One of the other things that we do is we train healthcare systems and clinics to start their own telemedicine programs. And about 6 years ago, we started the Show Me Echo program. Just to let you know, we do have some HRSA funding. We are funded as a regional telehealth resource center. Our telehealth resource center is called the Heartland Telehealth Resource Center, and it covers Missouri, Kansas, and Oklahoma. And our charge there is to answer any questions that people in our region have about telemedicine, and that could include reimbursement or legislation or regulation or questions about operations or the technology. Okay, so this slide, you guys might feel like you know this backwards and forwards already because it makes sense when we're talking about workforce and rural healthcare. So some of the reasons that we do telehealth and also the ECHO program is because of clinical shortages and clinical maldistribution. We do it to increase access, to decrease the need for travel. We know that early diagnosis prevents suffering, saves lives, and saves money. And we provide clinical education and training. And we also know that when you do telemedicine, it provides an economic development for that rural area by keeping the local keeping healthcare dollars local. And what I mean by that is, if you are able to see a provider without leaving your own community, then all of your labs, the fees that go to pay the healthcare provider, x-rays, pharmacy, all those dollars stay local. And that's the opposite if someone drives to an urban area and receives their healthcare away from their home. Okay. So we've been doing telemedicine in Missouri since 1994. It really is great. It really does work. It really does increase access. We used to ask every single telemedicine patient what they would do if they didn't have telemedicine. And there were really 3 categories of answers on this, and it was split pretty evenly between the 3. The first group would say that they would stick with their own primary care provider for all of their needs. So they would stay in their hometown and receive care there. About a third of the people said that they would drive to see their specialist. And about a third of them said that they wouldn't receive care if there wasn't telemedicine. And so we know that telemedicine increases access and it does reduce the need for travel, but it does have limitations. And the limitation is that when you do telemedicine, that healthcare provider that sees you can still only see one patient at a time. So we'll hear from Dr. Edison in a minute, but she's used telemedicine to see patients all over the state of Missouri, but there was still only one Karen Edison. And so she could still only see, maybe 25 patients in that time period. So telemedicine increases access, but it doesn't increase the capacity for care. And that's what we're here to talk to you about today. We run a program called ECHO, and it stands for Extension for Community Healthcare Outcomes. It connects interdisciplinary teams with primary care providers and other providers via video conferencing. They collaborate in a case-based learning environment, and it develops the skills and increases the use of best practices for the healthcare providers in that community. We are showing that it can increase availability and the quality of patient care in rural Missouri. This slide just shows you the difference between an echo model and a telemedicine model in regards to how many patients it can directly affect. And we firmly believe that there's a place for both telemedicine and for echo, and that they should work together. I want to give you an example of one of our echo hub teams, just so you kind of know how we do this. So probably a year and a half ago, Dr. Balasandran from the university called me and called Karen to talk about this idea that he had, this what he called a gap in knowledge. There's a gap in knowledge out there, and he wanted to address it. And after many conversations, we decided to help him work on a project called Foot Preservation Echo. And we love this description because it's exactly what the goal of this echo is to have people keep their lower limbs. And so as you go down this list of healthcare providers on this team, I just want you to kind of think about the different types of specialties and backgrounds and knowledge and experience that each of these people have. And this is a group that would be able to help a primary care provider think about how to best care for their patient without trying to refer them to who knows what. Do they refer them to vascular? Do they refer them to infectious disease? Do they refer them to any of these things? And so when we started working with this team, what they said they wanted to do was develop a pathway for healthcare providers to diagnose and recognize various etiologies of foot conditions and treat locally when feasible. In other words, let's not refer these patients out to a half a dozen different specialists and get that patient really frustrated with the healthcare system. Let's see what we can do for them right here in our own hometown. They also wanted to be able to optimize protocols, documentation, and reimbursement by healthcare providers for the management of diabetic foot, arterial and venous ulceration, and other foot-related conditions. You can see how specific they were in writing out their goals and objectives. And finally, just one more note about the foot preservation echoes is these are some of the topics that will be discussed during the didactic portion of these echo sessions. And the lecture portion or didactic portion is only about 15 minutes of the hour on these echoes. Whoops. So the way that this works, if you were to join an echo, is that as a participant, we would want you to send in a de-identified case so we can talk about your patient. Then the expert hub would review that case. And during the echo session, you would present the case in a de-identified way. And then there would be a facilitated discussion about it where recommendations are made. And then as a healthcare provider, you would take those recommendations and decide whether or not to use them with your patient. So just a little bit more about the history. We started this project. We started thinking about this project back in 2013. In 2014, we made it go for real. We were set to get $1.5 million from the state that year. Unfortunately, the governor vetoed all new spending, and we were left with none of that. But we did find a couple partners, and we did start 2 different pilot projects that year. And then after that, we have just grown like crazy. So the difference between an echo and a webinar are the use of these 4 things. The first thing is similar to a webinar, is using technology to leverage scarce resources. In the case of the echo, the knowledge and experience of the interdisciplinary hub team is the scarce resource. That's what we're leveraging. The second idea is to share best practices to reduce variation in care. And then we use case-based learning, which we talked about already. And the O in echo is for outcomes. And we have a robust evaluation methodology at Show Me Echo. And at this point, I'm going to hand this over to Dr. Edison.
Oh, good. Hi, everybody. I'd love it if you turn your videos on too. It's just more fun. But I just wanted to say, Rachel mentioned a minute ago that telemedicine and echo go hand in hand, and they certainly do. If some of you were at Dr. Youngwalker's talk earlier, she talked about the Mo CPET project, where they use phone calls to mentor folks around child psychiatry. Well, we do this in dermatology too. It's called Access Derm. There's a lot of telemedicine programs that run right alongside these echo programs. And if you've seen one of these echo programs, you've seen one of them. They all are unique in their own way. It's like everything on this screen I could talk about for an hour, so I won't, but let me just kind of go through it. And just to review, so the way an echo works, when you first start, you do introductions, and then you go through the principles of the echo. And that is, this is a learning collaborative. There are no dumb questions. We're friendly, we're collegial. We try to use first names. And we try to really level the playing field and not be hierarchical. When I lecture to doctors about this, I always say, this is like case conference or grand rounds, but without all the egos. So we try to make it very friendly because we're basing it on the principles of adult learning, what we know to be true from the adult education literature. And that is, if, as a doctor, if I go to a lecture and I take notes, it's very unlikely to change my practice. But if I enter into a learning collaborative where there's free exchange of information, where patient cases are discussed, that really does change practice. And so we think that over time, we're going to really improve the quality of care throughout every corner of our state. So pain management, as Rachel mentioned, was one of our first echoes that we got started because, as many of you know, we're still the only state in the nation without a prescription drug monitoring database statewide. Asthma was one of our early echoes, and you'll see several asthma echoes on this, and they have different goals and different audiences and different purposes. Hepatitis C is something that we're growing. There's a state effort to really locate people who are positive for Hep C and get them the treatment that they need. Opioid use disorder. And we have a star provider for Hep C, Sue Norris. She's in Ellington, right, Rachel? And she's like diagnosed and treated almost 100 people with hepatitis C, which is just unbelievable. Opioid use disorder is very needed. We talked about foot preservation. We also do education echoes. We just started one with the veterinary school on veterinary education, which is really fun. Dermatology, Highlands, Missouri, Highlands, Eminence. I knew it started with an E. Thank you. Eminence, Missouri. Susan Eminence. Dermatology is in many ways like child psychiatry. It's in very short supply and it's hard to get people in. So we really have gotten the dermatology going early, and there's been a lot of robust participation in that. Community health worker is one of our busiest echoes. Autism is one of our original echoes, and you'll see more than one autism echo on this. Again, like asthma, different goals, different missions, different objectives. Kidney disease, much needed HIV. We have a moms and babies echo around high risk OB issues. And we have mother, infants, and neonatal abstinence syndrome, where babies are born addicted to opioids. Developmental disabilities, child psychiatry, Head Start, you can read them. We just started a suicide prevention echo, and it's been unbelievably well attended. Through the pandemic, we've seen an uptick in suicides and uptick in mental health issues. Hypertension, certified peer specialists. These are folks with mental health or substance use disorders. And these are certified peer specialists who are people who've had some of those challenges, who are there to help others, help people with those conditions. Diabetes is an echo that we rebooted. Dr. Betty Dries is our lead there, and it's going great guns and is much needed in our state, as is oral health. And, I could talk about any of these echoes. I will mention that when COVID happened, in mid-March, we started a COVID-19 echo at noon on Mondays, and Dr. Randa Williams, who just left the Department of Health, he was the lead for that echo, but we're still having it every Monday at noon. And it's kind of our public health facing COVID echo. We have a COVID-19 and kids echo on Thursdays for pediatricians and school nurses and folks like that to talk about COVID as it relates to kids. We have a hospital-focused COVID echo on Tuesday late afternoons for intensivists, and we have ID docs and all kinds of people like that in the managing hospitals and patients in a pandemic echo. And I see it's not up here, but we've had a 16-week nursing home echo. We've had together with across the country. That was a HRSA, that was an ARC-funded IHI, Institute for Healthcare Improvement, Project Echo in New Mexico collaborative. And so we've had 4 COVID echoes through this pandemic so far. We also, because of the pandemic, started a telemedicine echo, because before the pandemic, most healthcare providers did not use telehealth. And since the pandemic, most healthcare providers have or are using telehealth. And so there was a real need to help people learn how to use that technology. And then the other thing we did at the Missouri Telehealth Network around the pandemic is we got funding through the Missouri Department of Economic Development to give out 1,500 hotspots through community health centers and others so that patients could connect to their healthcare providers. And if it was a family with children, then those kids could connect to their schools. And so that hotspot program was a really important program, I think, for our state. Can I have the next slide? These are some echo topics that are under discussion or in planning. Next Friday, actually, we're having our all-day planning process for the childhood weight management echo. Some of you who deal with children may know that there's a new benefit coming online in Medicaid, where there's a payment for a multidisciplinary approach to family care for childhood obesity. So that's an important echo to get that information out for folks. Eating disorders, eye care, foster care, dementia and Alzheimer's care. We're forming up that team right now, and that's a very important and very needed echo in our state. We have some other echoes funded by other folks. HRSA is funding a rural health preceptors quality improvement echo, and then we're going to start Heartland Regional Genetics. Social and emotional learning in schools, that's another education echo. On the bottom there, we have 2 echoes that are planning stage related to the University of Missouri's Next Gen Precision Health Initiative. And one of them is precision health and cancer care. You may know that the science has rapidly changed, and we know a lot about the new targets for different kinds of cancers and new medications that have been developed because of those genetic advances. And so we now need to look at the different cancers we diagnose in terms of their markers so that we can better talk about not only prognosis, but therapy. Which of the new checkpoint inhibitors, which of the new biologics that are coming online are going to be effective in that patient? That's precision health. And so we're getting ready to start a precision health cancer care echo to make sure that every Missourian, no matter where she chooses to live, has access to the newest medications and the newest therapies. And then finally, this research and training one, if there are people out there that want to get involved in research with the university as true partners, we're going to do a training echo and train them up to do clinical research so that we can partner together in that moving forward. Next slide. This is a map. It's pretty recent, just showing many of our echoes and where different primary care participants are in the state. You can see there are still a few blank counties, Monroe and Rawls, but we're trying to get out there and get the word out. We're working with Extension. We're actually funding 23 Extension agents to help with us to get the word out about echo throughout the state. And that's been a really successful partnership so far. We're excited about that. And let's see, next slide, I guess. Oh, this is one of the last slides. Just a few numbers, the things we know. We have a robust evaluation team, and there's a robust set of evaluations going on right now. And we feel a real duty to do that because Missouri has embraced the ECHO model maybe more robustly than other places. And so we really feel like it's our job to do a good job doing the research showing the value. Through the Derm Echo, we know that at least 100 melanomas have been diagnosed from our participants who say they wouldn't have otherwise, because you go to your primary care now and they listen to your heart and lungs through your clothes, right? And so 2/3 of our melanoma patients have seen their primary care within the last year, but they didn't ever see the melanoma forming up on their skin. So, and we know that men over 50 in Missouri are the ones who die of melanoma in greater numbers, because especially those who live alone. So if you know a man 50 or older who lives alone, somebody needs to look at his back, the back of his neck, and the back of his ears. Okay. So we've trained our primary care people to do this, and they're finding these melanomas, which is great, because if you catch melanoma early, you live, and if you don't, you die. It's just about that easy. I talked about people being diagnosed and cured in regions of our state where they wouldn't have otherwise, through the support of the hepatitis C echo, through our robust autism echoes. 100% of Missouri families now live within 60 miles of a echo autism diagnostician. So before, Medicaid would require that children be diagnosed by an autism expert before they would pay for the specialized therapies that those kids need. And now if a pediatrician jumps through some other hoops and participates in echo autism, the state deems them worthy of being a diagnostician. And that's really important. So those kids can get those therapies and those interventions while they're waiting on their appointment, at one of our 6 autism centers in the state. Also, it looks like we're saving, about $4 million a year in decreased hospitalizations and ED visits through our set of asthma echoes. And those are through decreased hospitalizations and decreased ED visits. So we're really, really, really excited about that. And so, but we're really looking at a whole set of evaluations. Luckily, we have a partnership with the Center for Health Policy. And we have the MoHealthNet administrative claims data. And so we can use, in partnership with the state, we can use those data to really look at what we're doing through our echoes, particularly for our most vulnerable citizens. And I have to tell my mom I can't talk right now. Okay, I just did that. For our most vulnerable citizens, so that we can really see what the impact is on what we're doing. We do a whole variety of evaluations, all the way from self-efficacy. Do I think I know what I'm doing? And that's interesting. In a lot of our echoes, people's self-efficacy is pretty high, and then they attend for a while and it goes down. And then they attend a while longer and then it goes up, which is really fun, because people just don't know what they don't know, right? They just don't know what they don't know. So next slide.